The ulnar nerve is formed from the anterior division of the inferior trunk. And if you pull out your handout materials and refer to your diagram of the brachial plexus, you'll see that the anterior division of the inferior trunk, which is formed from the nerve roots of C8 and T1, the inferior trunk divides into anterior and posterior divisions, and the anterior division continues along uninterrupted and then breaks out into several named peripheral nerves of the upper extremity, at least two of which are cutaneous sensory nerves of the upper arm and forearm. And then the ulnar nerve comes off distally off the medial cord before the medial cord joins with the lateral cord to form the ulnar nerve. So the ulnar nerve is largely, and I'll say almost completely, comprised of nerve roots from C8 and T1. And some references will say that there is an inconstant contribution from C7. And indeed, the AMA guides describe an inconstant or infrequent contribution from C7. But if you look at general standard diagrams of the brachial plexus, you'll see that, at least according to diagrams that you'll find, there's no way that C7 can contribute to the ulnar nerve. But of course, the diagrams that we see in anatomy textbooks and anatomy atlases don't take into account the multitudinous possibilities for anomalous developments of the brachial plexus. So in general, we consider the ulnar nerve to be largely C8 and T1, but also remember in the back of your mind that there's a possibility of inconstant contribution also from C7. Now, if you go back and refer to the diagram in your handouts that shows a cross-section of the upper arm, recall that the radial nerve passes down the arm immediately posterior to the humerus in the posterior compartment of the arm. The ulnar nerve also travels down the arm in the posterior compartment of the arm, but it has a different distribution than does the radial nerve. The ulnar nerve passes down the medial aspect of the upper arm, whereas the radial nerve travels down in the lateral aspect of the upper arm. The ulnar nerve also travels at a greater distance from the humerus than does the radial nerve. The ulnar nerve travels in the intermuscular septum between the medial and long heads of the triceps brachii muscle. And the ulnar nerve travels posterior to the medial epicondyle of the humerus, and then the nerve becomes superficial in the ulnar tunnel, again, but still in the posterior aspect of the upper arm. As the ulnar nerve comes down through the ulnar tunnel, or the cubital tunnel as it's often referred to, it becomes superficial there, and you can even feel the ulnar nerve as a little piece of cord or a little rounded noodle in the cubital tunnel. And from there, it progresses down the medial aspect of the anterior forearm, and then enters into the hand as it passes through the Tunnel of Guyon, and then sends branches into the ulnar aspect of the ring finger, and then into the radial and ulnar aspects of the index finger. Okay, so let's review now some of the functions of the ulnar nerve. And like the radial nerve, the ulnar nerve has the three main types of function. It has motor function, has sensory function, And then, of course, it also has autonomic function. So let's talk about the major functions here of the ulnar nerve. Okay, now the ulnar nerve in the forearm, as it passes through the forearm, is largely C8. Largely consists of fibers from the C8 spinal nerve. And if there is at all any contribution from C7, remember we said that the ulnar nerve has inconstant contribution from C7, but if there is contribution from C7, this is where we would find it. We would find it in the forearm. In other words, C7 fibers would not innervate muscles of the hand. But if there is contribution from C7, we would find it contributing to innervation of muscles in the forearm. But let's focus our consideration that muscles served by the ulnar nerve in the forearm are largely C8. Okay, and so in the forearm, major muscles supplied by the ulnar nerve include the flexor carpi ulnaris and the flexor digitorum profundus muscles to the third and fourth digits. Third and fourth digits, meaning the ring and pinky fingers. Okay, so the function of the flexor carpi ulnaris is ulnar wrist flexion or wrist adduction, or I should say and or wrist adduction. And if we could separate wrist flexion and isolate the action of the flexor carpi ulnaris isolated from the function of the flexor carpi radialis, if we could have contraction only of the flexor carpi ulnaris, we would find that that muscle causes both a combination of wrist flexion and also wrist adduction. Wrist adduction also being known as ulnar deviation. And you can demonstrate this to yourself by just taking your wrist and flexing it first of all, and you can see visible contraction of the flexor carpi ulnaris muscle. And then also in a wrist neutral position, if you just perform radial deviation, you will feel and see contraction, at least on the volar surface of your forearm, contraction from the flexor carpi ulnaris. So the flexor carpi ulnaris sort of splits the vector between wrist flexion and wrist ulnar deviation. So we refer to that movement as ulnar wrist flexion. The flexor digitorum profundus muscle to the third and fourth digits. Recall that the flexor digitorum profundus goes all the way to the distal phalanx, crosses the distal interphalangeal joint, and so this muscle causes flexion of the distal phalanges of the distal ring and pinky fingers. And we're going to see later when we discuss the median nerve, the flexor digitorum profundus muscle has dual innervation. The portion of the flexor digitorum profundus that goes to the index and middle fingers is innervated by the median nerve. But at least the ring and pinky fingers are innervated by the ulnar nerve and largely C8 fibers found within the ulnar nerve. Then, as the ulnar nerve passes into the hand, the major contribution to the ulnar nerve is from fibers of C8, and now also we see some T1 fibers showing up down to innervate myotomes in the hand. So in the hand, the ulnar nerve innervates 3 of the hypothenar muscles, and we'll discuss those here as we go. Innervates also the interossei muscles on both the dorsal and palmar aspect of the hand. And on the dorsal aspect of the hand, there's actually 4 interossei muscles, while on the palmar surface of the hand there are 3. The ulnar nerve innervates the adductor pollicis muscle, that's adductor, ADD, adductor pollicis muscle. That gives us the basis for our Froment's test, which we'll discuss here shortly. It innervates also the flexor pollicis brevis, the ulnar head of the flexor pollicis brevis muscle, and also innervates the medial two lumbrical muscles. And by medial, we're talking about in the anatomic position. So those are the two lumbrical muscles on the ulnar side of the hand. With respect to the hypothenar muscles, give us adduction and opposition of the fifth finger. So you can demonstrate those to yourself as you look down at your hand. You can adduct the little finger and you can oppose the little finger. Those are controlled by the hypothenar muscles, and we'll break those out here into individual muscles in a moment. The dorsal and palmar interossei muscles cause abduction and adduction of the second through the fourth fingers, and for the dorsal interossei, those are the abductor muscles. The palmar interossei are the adductor muscles of the second through the fourth fingers. The adductor pollicis muscle causes thumb adduction. The flexor pollicis brevis causes flexion of the proximal thumb phalanx. Wouldn't be the distal phalanx, that would be the flexor pollicis longus muscle. And then finally, the medial two lumbrical muscles cause extension of the middle phalanges, of the ring and the pinky finger. And what nerve was responsible for extension of the phalanges of the middle finger, index finger, and thumb? That was the radial nerve through the extensor digitorum communis. Well, the extensor digitorum communis and the extensor digiti minimi, also served by the radial nerve, they give us extension of the distal phalanges of the ring and the pinky finger. The middle phalanges of the ring and the pinky finger are extended by the medial two lumbricals, and those are served by the ulnar nerve. Okay, so let's talk about this in a little more detail now. As the ulnar nerve continues down in the forearm and passes into the hand, in order to get into the hand, it passes through a little tunnel in the wrist known as the Tunnel of Guyon. We'll talk more about the Tunnel of Guyon in just a minute. But as the ulnar nerve passes through the Tunnel of Guyon, it then branches into two main branches. There's the hypothenar branch, and then there is the deep branch, and both of those are motor branches. And we'll talk about the sensory distribution of the ulnar nerve in just a minute as well. But these are the motor branches into the hand. So two main branches, the hypothenar branch and the deep branch. And as the name suggests, the hypothenar branch goes to the three hypothenar muscles. And the three hypothenar muscles are the abductor digiti minimi, that is, the flexor digiti minimi, and the opponens digiti minimi. And you should remember the abductor digiti minimi. And if you look down at your hand, put your hand in ulnar position and abduct your pinky finger, you see that the abductor digiti minimi is on the most medial aspect of the hand, and you can palpate that muscle as you abduct your pinky finger. That is purely innervated by the ulnar nerve. And many electrodiagnostic studies use the abductor digiti minimi as a sole representation of the function of the ulnar nerve below the wrist, or the ulnar nerve hypothenar branch as it goes into the hand. The deep motor branch serves many muscles, including the 4 dorsal interossei muscles. Those are responsible for abduction of the 2nd through the 4th fingers. They serve the 3 volar interossei muscles, and those are the adductors of the 2nd through the 4th fingers. Serves also the adductor pollicis and then the flexor pollicis brevis. All those total of 9 muscles, 9 small finger muscles, served by the deep branch. And it's the deep branch that extends all the way over to the thumb as it innervates the adductor pollicis and the flexor pollicis brevis, while the hypothenar branch remains isolated to the pinky finger. Okay, so those are the major motor functions of the ulnar nerve. What about the sensory distribution of the ulnar nerve? Well, the ulnar nerve, as it passes below the elbow, sends off a dorsal sensory branch. It gives this branch off about 5 centimeters proximal to the wrist. So it's interesting to note that the ulnar nerve does not provide sensation in any region of the forearm, whether we're talking about the volar aspect of the forearm or the dorsal aspect of the forearm or the radial aspect of the forearm or the ulnar aspect of the forearm. The ulnar nerve does not provide sensation to the forearm. It begins its sensory function in the hand and down below the wrist. And it does that by sending off a branch approximately 5 centimeters proximal to the wrist. This is the dorsal sensory branch. And the dorsal sensory branch provides sensation to the ulnar aspect, ulnar surface of the pinky finger, and then also to the 4th web space, which includes the radial surface of the pinky finger and the ulnar surface of the ring finger. Okay, and the ulnar surface of the pinky finger is considered the autonomous zone or the pure patch for ulnar nerve sensory function. So I want you to just take a look at your own hand, go up to the distal phalanx of the pinky finger and look at the distal ulnar aspect of the pinky finger, and that is purely served by the dorsal sensory branch of the ulnar nerve. Also below the wrist is sent off a secondary dorsal sensory branch, and this also serves the radial surface of the pinky finger, the ulnar surface of the ring finger, and then it also has a sub-motor branch that provides motor function to the 3rd and 4th lumbrical muscles. Now, the AMA guides give us a good depiction of the ulnar nerve, and as I said earlier regarding the radial nerve, I like the diagram in the AMA guides on page 487. It shows that the ulnar nerve has its major contributions from the C8 and T1 nerve roots, and then it also indicates by use of a dashed line, and what they're indicating by the use of the dashed line is that there is inconstant contribution from C7, but they indicate that there's possible contribution from C7 in the event of anomalous development of the brachial plexus, which we referred to earlier. So the ulnar nerve continues unbranching all the way down in the posterior compartment of the upper arm in the intermuscular septum, and then it's not until it passes immediately below the elbow that it sends off motor branches to the flexor carpi ulnaris and also the flexor digitorum profundus muscle, at least those parts of the flexor digitorum profundus that serve the ring and the pinky fingers. The ulnar nerve then continues down the forearm, again unbranching, until it passes then below the wrist. Below the wrist, it sends off several branches. It sends off a small branch to the palmaris brevis. As we said earlier, it sends off branches to the 3 hypothenar muscles. Sends off branches to the lumbricals, to the 4th and 5th digits. It sends off many branches to all the dorsal and palmar interossei muscles, and then it sends off individual branches, as we said, to the adductor pollicis muscle, and also the ulnar head of the flexor pollicis brevis muscle. And you can review that diagram in the AMA guides, page 487. Interesting how the ulnar nerve is that it continues all the way down the humerus unbranched. So it has no function in the upper arm at all. It's not until it passes the elbow that it sends off some motor branches, and then after those motor branches leave the ulnar nerve continues down into the wrist and hand, again unbranched, until it innervates muscles into the wrist and hand. Now there is a sensory branch that passes off the ulnar nerve just 2 inches proximal to the wrist, but that does not provide sensory function in that area. It provides sensory function down below the wrist and into the hand, which we will discuss here shortly. And so, knowing the course of the ulnar nerve down into the forearm, wrist, and hand, what are some possible locations where the ulnar nerve could be entrapped? Well, there are 3 possible locations where the ulnar nerve is commonly entrapped. 2 of those are at the elbow at the cubital tunnel, and 1 is below the wrist at the Tunnel of Guyon. Now, in the cubital tunnel, the ulnar nerve can be compressed either by the arcuate ligament or by the head of the flexor carpi ulnaris muscle, or at the wrist, the ulnar nerve can be compressed as it passes through the Tunnel of Guyon, which is a small passageway that is between the hook of the hamate bone and the pisiform bone. So let's talk about each of these possible locations of ulnar nerve entrapment. Now, the cubital tunnel is right below the elbow, and I'd like to have you palpate your own cubital tunnel, and you can feel the borders of the cubital tunnel, and you might even be able to feel the ulnar nerve as it passes through the cubital tunnel. Medially, the cubital tunnel is bordered by the medial epicondyle. Laterally, it's bordered by the olecranon process of the ulna bone, and you can feel both of those landmarks. If you just roll your index finger over the cubital tunnel, you'll feel the medial epicondyle medially and the olecranon process of the ulna laterally. The floor, the so-called floor of the cubital tunnel, is formed by the medial collateral ligament, and then the ulnar nerve sits in the floor of the cubital tunnel and is covered by the ulnar collateral ligament. It's covered by an aponeurotic connective tissue roof, and it's covered by the tendon of the flexor carpi ulnaris, also known as the arcuate ligament or Osborne's ligament. Now, the cubital tunnel is slack, meaning that all tissues that pass over, around, and under the cubital tunnel, such as the ulnar collateral ligament and the tendon of the flexor carpi ulnaris, all those tissues are slack during forearm extension, and they become progressively more taut during forearm or elbow flexion. And as they become more taut, they compress on the ulnar nerve. And if you've ever done much weightlifting, you may have experienced a compression of the ulnar nerve at the cubital tunnel with exercises such as bicep curls or power cleans or even tricep extensions, or any exercises that cause a hyperflexion at the elbow. For me, I noticed this tweaking of the ulnar nerve by power cleans. And power cleans cause forceful and resistive elbow hyperflexion. And I often will get a little tweak on the ulnar nerve. It gives me a little sensory zing down into the ring and pinky fingers. And that's because all these tissues become taut during elbow flexion. And the point of constriction of the ulnar nerve is maximal about 1.5 to 3.5 centimeters distal to the medial epicondyle. So if you place your thumb over your medial epicondyle in the region of the cubital tunnel, approximately 1 thumb's width distal to the medial epicondyle is where the point of constriction of the ulnar nerve is going to take place. Now, with compression in this area, we're going to see that the flexor carpi ulnaris and the flexor digitorum profundus to the 3rd and 4th digits are usually spared, because by now those branches have already left the ulnar nerve. And so those muscles are spared. But you'll have an aching pain at the medial elbow. You'll have sensory findings at the 4th and 5th finger on the ulnar side of the hand. And generally with compression in the cubital tunnel, motor findings are either rare or they are very late findings, if indeed motor findings occur at all. With compression of the ulnar nerve at the Tunnel of Guyon, we're going to see a different set of symptoms, mostly down now into the hand. So what about the Tunnel of Guyon? Okay, well, the Tunnel of Guyon is a passageway approximately 4 millimeters long. It begins at the proximal aspect of the transverse carpal ligament, and it ends at the aponeurotic arch of the hypothenar muscles. And if you feel your own pisiform bone, you'll note that there's a depression between the pisiform bone and the hook of the hamate bone. And this creates a fibroosseous tunnel that's covered across the top by the piezohamate ligament. Piezohamate ligament. So picture that. You have this depression between the pisiform and the hook of the hamate, which is covered over the top by the piezohamate ligament. And then on top of the piezohamate ligament, you have the volar carpal ligament. It's the volar carpal ligament that serves as the attachment point for the hypothenar muscles. Now, the ulnar nerve passes through the Tunnel of Guyon, and within the Tunnel of Guyon, it bifurcates. And it bifurcates into a superficial branch, and it's the superficial branch that is more ulnar in the canal, more ulnar in position in the canal, and that's a sensory branch. And then it also bifurcates into the deep branch, and the deep branch is located more radially in position within the canal, and it's this branch that carries the motor branches into the hand. And we talked about the muscles that the motor branches serve, and we'll go into a little bit more detail on those here in just a moment. So if you have your handout materials, I have for you a image that depicts a cross section taken through the wrist, looking from the top of the wrist down into the hand, and it shows the Tunnel of Guyon, formed by a fibroosseous tunnel between the hook of the hamate and the pisiform bone, and then covered across the top by the pisohamate ligament and the volar carpal ligament, and then through the Tunnel of Guyon past both the ulnar nerve and the ulnar artery. And so this is a common site of compression for people who are involved with repetitive hand use or compression on the palmar aspect of the wrist and hand. Also in your handout materials, I have an excellent image that demonstrates the bifurcation of the ulnar nerve within the carpal within the Tunnel of Guyon, and it divides into the more ulnar located superficial branch and the more radial located motor branch. And depending upon where the compression or irritation of the ulnar nerve takes place, will determine what types of symptoms you're going to experience, or what kind of symptoms your injured worker is going to report. So you can imagine that we can have high Tunnel of Guyon lesions, middle Tunnel of Guyon lesions, and even low or distal Tunnel of Guyon lesions. And here's another diagram for those of you that have your handout materials. As the ulnar nerve passes underneath the pisohamate ligament, there's several possible syndromes that can result depending upon which branch is compressed. Recall that the motor branches go to the hypothenar muscles, the dorsal and palmar interossei muscles, the adductor pollicis muscle, and also the flexor pollicis brevis muscle. So with compression on the motor branch, we're going to have motor findings such as atrophy, weakness, etc. And then with compression on the sensory branches, we're going to have sensory findings on the ring and pinky fingers. Okay, and compression lesions of the ulnar nerve are typically described as falling into one of three different types based upon the anatomic location of the compression. Type 1 lesions are a proximal compression of the ulnar nerve, meaning that the compression takes place at the proximal edge of the palmar carpal ligament prior to the bifurcation of the ulnar nerve into its sensory and deep motor branches. So it leads to both sensory and motor findings since the compression is prior to its bifurcation. So, for example, would lead to motor weakness in all of the intrinsic muscles of the hand, at least those that are innervated by the ulnar nerve. And then there would be sensory loss in the region of the hand served by the ulnar nerve, which would be the entirety of the medial aspect of the palm, the entirety of the pinky finger and the ulnar aspect of the ring finger. Now, type 1 or zone 1 lesions of the ulnar nerve, entrapments of the ulnar nerve in zone 1 causing a type 1 lesion, these are most commonly due to fractures of the hook of the hamate, and to a lesser extent caused by ganglions that compress on the tunnel of Guyon, and then therefore cause narrowing of the tunnel and cause compression on the ulnar nerve prior to its bifurcation into motor and sensory branches. A type 2 compression happens slightly more distal, and it's a compression at the bifurcation of the ulnar nerve just distal to the fibrous arch of the hypothenar muscles. And this is the most common type of compression of the ulnar nerve within the tunnel of Guyon. Results in symptoms associated with type 1, as we just discussed. However, the sensory branch to the dorsal part of the hand and the motor supply to the muscles of the base of the palm are unaffected. So type 2, in contrast to type 1 lesion, involves an impairment in motor function of the hand with sensory function unaffected. And again, this type of lesion is most commonly found with fractures of the hook of the hamate and also ganglions. However, because of the location of the compression of the ulnar nerve, the pattern of symptoms is most predominantly motor versus sensory. So in general, sensory function in type 2 lesions is unaffected. Then we have the type 3 lesions, and this is the least common type of compression of the ulnar nerve within the canal of Guyon, and this involves a compression of the superficial branch of the ulnar nerve at the most distal aspect of the tunnel of Guyon, and this results in a loss of sensory function from the cutaneous territory of the hand, but because the deep motor branch is spared, there's no motor involvement. So these ulnar nerve lesions can be localized based upon whether or not they produce motor findings, sensory findings, or combination of motor and or sensory findings, with zone 1 or type 1 lesions causing both motor and sensory abnormalities, type 2 lesions causing primarily motor abnormalities with sensory function spared, and type 3 lesions causing sensory findings only with motor findings spared. And the most common cause of type 3 compressions of the ulnar nerve within the canal of Guyon is due to thrombosis of the ulnar artery. Okay, so let's review now. With compressions of the ulnar nerve, and this is going to vary based upon the location of the compression, but just considering the entirety of the distribution of the ulnar nerve, with deficits of function of the ulnar nerve, we're going to have motor findings that include weakness of wrist flexion and or wrist adduction, and we call that ulnar wrist flexion. We're going to have weakness of finger flexion of the distal interphalangeal joints of the 4th and 5th fingers. And we're going to have wasting and weakness of the small hand muscles. And if you've ever seen a person with wasting and weakness of the small hand muscles, it's usually quite prominent in the dorsal interossei muscles and the dorsal abductor interossei muscles. You'll see depressions between the metacarpal bones that make the metacarpal bones quite pronounced and make the hands appear to be quite bony, and that's due to atrophy and wasting of the palmar and dorsal interossei muscles. We're going to have sensory findings such as tingling and numbness in the ring and pinky fingers. And if you've ever hit your ulnar nerve as it passes through the cubital tunnel, or so-called struck your funny bone, you'll know the distribution of the ulnar nerve, because you get that zing, that sensory tingle all the way down into the ring and the pinky fingers, and that's exactly the distribution of your ulnar nerve. So you probably have first-hand experience with that. And then also we're going to have autonomic deficits as well, because the ulnar nerve does carry autonomic fibers. So what kind of autonomic deficits would you think would be associated with the ulnar nerve, or with compression on the ulnar nerve? Well, again, by analogy to Hilton's law, the ulnar nerve serves the dermatome regions, as we just described. It's the ulnar aspect of the hand, and so autonomic disturbances would likely be localized to this dermatome region, and would include findings related to abnormal function of blood vessels and glands, particularly sweat glands in this area. So hyperhydration would be related to excess glandular function. Vascular findings would include blanching of the fingers, hyperemia of the fingers, clubbing perhaps of the fingernails, flaking of skin of the ring and pinky fingers, and etc. So we can see any combination of motor findings, sensory findings, and also autonomic findings. So let's talk about what types of physical exam findings we're going to see with compression of the ulnar nerve. Well, with a high ulnar nerve lesion, for example, ulnar nerve lesion up high in the Tunnel of Guyon, we're going to see sensory findings in the fourth and fifth fingers. And we might see autonomic findings as well. Motor findings here are uncommon, and it's not known why, but many times motor findings with a high ulnar nerve lesion are either late or rare findings, if at all. On physical exam, we're going to have a positive Tunnel sign at the elbow, which is a tapping over the ulnar nerve, will give a sensory distribution of pain, numbness, and or tingling. And we're going to have a positive forearm flexion test. And to do the forearm flexion test, you simply ask the person to flex their forearm as much as possible to the extent of active range of motion, and then you, the examiner, apply slight overpressure, taking the forearm into passive hyperflexion. This causes a tightening of the soft tissue contents of the tunnel, the cubital tunnel, and causes compression of the ulnar nerve, and again will give sensory symptoms down into the ring and pinky finger. On physical exam, we're also going to see a positive Froment sign. And we'll talk about Froment sign when we get into some more examination procedures. But a positive Froment sign is due to weakness of the adductor pollicis muscle. And I remember back in chiropractic school, I was taught the Froment's sign, or the Froment's maneuver, to be done by placing a piece of paper, or sometimes a dollar bill, in between the thumb and the lateral aspect of the index finger, and asking your examinee to resist your attempt to pull the dollar bill or the piece of paper out from in between their thumb and index finger. And with an ulnar nerve lesion, due to weakness of the adductor pollicis, they simply either cannot adduct the thumb sufficiently to hold a piece of paper in between that web space, or strength of the adductor pollicis is reduced, and therefore it's unable to resist your attempt to remove the piece of paper from in between their fingers. With lesions in the Tunnel of Guyon, we're going to see more findings down into the wrist and hand. Specifically, we're going to find weakness of the dorsal and palmar interossei muscles. We're going to find weakness of the flexor pollicis brevis, and we're going to find weakness of the lumbrical muscles, but generally motor function of the flexor carpi ulnaris and the flexor digitorum profundus muscles would be spared, because by now those motor branches have already come off up in the elbow region, and would be spared in lesions more distal in the Tunnel of Guyon.